welcome to the Fireside Chat. Love to have you both. Before we start, Praveen, you're at what, Buffalo?
University at Buffalo. That's right.
Wonderful. Can you tell us about your title and where you are in your career? And then Victoria, we'll start with you, and then we'll grill you on a whole bunch of questions.
Okay.
Look forward to the barbecue. It's lasers. What can get better, right? So I'm Praveen Arany. First of all, thank you, Kyle and Mitch. We've been colleagues for a while, but I think this is my first fireside chat. So thank you for having us. I am trained as a dentist and a biomedical engineer, and I'm currently an associate professor with tenure at University at Buffalo. My primary appointment is in the dental school in the Department of Oral Biology. Given the nature of our work, I also have adjunct appointments in biomedical engineering and the Department of Surgery.
Wonderful. Victoria, please tell us about yourself.
Yeah, I'm Victoria. I am now finished my postdoc studies on Photobiomodulation. I'm from University of São Paulo, Brazil. Now, as I told you, I conclude my PhD doing some experiments during 1 year in Buffalo University, and then I come back to Brazil to finish my studies. And now I'm concluding this, looking for the effects of photobiomodulation on wounds and pain. And I'm so excited to share with you the results.
Wonderful. I love the paper. I think there's this journal had a lot of photobiomodulation in it, and it was really a spectacular journal. And thank you guys for coming on. So I'll let Kyle go ahead with questions, and then I'll jump in.
Yeah, sounds good. And I'm really excited to talk about this paper as someone that's in the biophotonics field, and it's great that you guys are looking at the mechanistic underpinnings of these light matter interactions. And I guess before we start getting into some detailed questions, do you want to give us kind of a high level summary of how this paper came about and its findings, just to kind of start off?
Okay, can I start? Do you want to start,
Yeah.
Doctor?
I was going to just say that maybe the audience is not very familiar with photobiomodulation, so maybe a little bit of context there, and then maybe we can talk about this specific motivation for this paper. So photobiomodulation has been around since the 60s. The light as a therapy has been around forever, but I think the formalized use of light for this particular treatment was first observed when the laser was used on biological tissue. When the laser was the device was made and it was used, they observed a stimulatory effect of low power light. And this came to be known, I believe there's a running count right now of how many names this treatment has. And the most popular one on Instagram is red light therapy. And you hear everyone from Ronaldo to the Kardashians using it. So I'm sure someone has heard of a term that actually describes it. The official term is photobiomodulation, which was coined in 2015. And this is the PubMed index term for the literature. So we use low amounts of light, and depending on how you use the light, we can reduce pain or inflammation or stimulate healing. It was actually one of the first observations in wound healing where they found that they could stimulate the healing response. And this would be a good handoff to Victoria, because she came to our lab with a very nice clinical observation in diabetic wounds. Victoria?
Yeah. I started this translational study in Brazil, in a hospital, in a public hospital in Brazil. So we decided to use photobiomodulation as an adjunctive therapy in only healing, but also in pain, because most of the diabetic patients has what we call neuropathic pain, diabetic neuropathic pain. So why not use photobiomodulation, since the the usual medication sometimes works, sometimes not, sometimes has collateral effects. So if we can help those patients in improving quality of life, so we decided to use photobiomodulation therapy, which is easy to use, which is cheap. When we call in a country like Brazil, in a public hospital, you have so many difficulties to treat patients, especially diabetic patients, that are so many. So this one-on-one form to improve health, quality of life, and also to decrease how much money we spend in the treatment of patient. So talking about photobiomodulation, with side-tube photobiomodulation, because many of those patients, they came from vascular therapy with gigantic wounds and a lot of amputations. So we started with the treatment for 7 weeks, twice a week, using red light. And then we saw those patients twice a week. And we saw amazing results after 7 weeks. And then how we will explain the mechanism for people, because we see this working, but we should explain why. So this is why we decided to do also in vitro studies to explain how this light is work on cells and explain the vascular mechanisms. This is why I decided to go to Dr. Arany lab to study the effect of modulation on endothelial cells.
Great, wonderful.
And so you're delivering 660 nanometer light, red light, at about I think it's 10 milliwatts per centimeter squared for 200 seconds. So for a layperson, what does that mean? And I guess, can you put that in the context of, say, direct sunlight versus the light indoors? Is this, the equivalent of a bright indoor light, or, it sounds like it's orders of magnitude less than direct sunlight.
Go ahead, Dr. Arany.
Yeah, so this is actually absolutely spot on, Kyle. I think one of the most common questions we get asked is, why don't we just go outside and lay in the sun, right? And that's got lots of advantages, but also certain difficulties, especially if you come from Buffalo, right? So if you look outside, it's all snowed out today. So clearly the sunlight is very helpful, both for, our mood, our depression, our circadian rhythm. But this particular treatment requires, it can be performed with a laser or an LED, but the wavelength and the amount of energy or dose is critical. And this is what has actually held the field back from becoming a mainstream treatment. So if you look at our figures in our paper, specifically figure 2, we actually have spent a lot, Victoria has spent a lot of time actually precisely outlining how much energy for how long, and has come up with the numbers that we have continued to use for different biological functions, endothelial responses, everything from proliferation, migration to organization of the vasculature. And as Victoria pointed out, why endothelial cells? Because that is one of the most important targets of our treatment. This treatment has been used in a wide range of wound healing scenarios, especially in oncology or supportive cancer care. And we have this condition called mucositis, where you get these ulcers in your mouth. This treatment is now actually standard of care based on systematic review and meta-analysis. And this year, 2026, coming year, we are actually going to have insurance codes reimbursing this treatment.
And, and sometimes, in popular science, we hear about blue light therapy as well. So, why specifically red light, versus other wavelengths in this case?
So if you look at the dosimetry description of how we use the light, we actually use the term Einstein to refer to the amount of energy. And that terminology actually has come about because people are using blue, violet, infrared, and other green and yellow light to do these treatments. So it's like comparing, apples to oranges, or in this case, watermelons to grapes, right? Like different amount of photon energy. So we do know that different wavelengths are effective. And as a clinician, people usually use a visible color like blue or red when they're trying to treat surface wounds. But when they want to treat deeper tissue, they prefer using near infrared. So that has been the clinical distinction of why one color of light has been used. But now with all these mechanistic studies, we are doing comparative analysis. So we are actually comparing the photon energy of a blue photon in blue light versus a red photon in red light. So That kind of accuracy, precision has now come about because we understand cellular responses.
And in terms of light delivery deeper into tissue, it absolutely makes sense that you use red light or near infrared light, of course, compared to UV light. Anyone that's put a laser pointer on their finger can appreciate that if they've compared like a green and a red laser pointer, right? But I think when we think about what are these photons doing to our cells and the proteins within them, I mean, certainly we're going to have different absorption spectra for different things. So I would think that from a mechanistic standpoint, blue and versus red are targeting very different things. Is that correct?
That is true. One of the big advances in our field is that we have moved away from absorption to inelastic scattering. So when you think about how is it that so many wavelengths of light have been used, and again, we point to the clinical phenotype, if you will, right? Patients getting better is, I think, the absolute endpoint for many of our observations. And if patients are getting better, there must be mechanisms beyond, classical photoabsorption pathways, right? So I will defer to Victoria in a second, but why she chose red light for her treatments. But our understanding of the mechanisms has also dramatically improved, which was one of the motivations of why Victoria came to our lab. We have actually shown that the growth factor that we all love and praise, TGF-beta, turns out to have a single amino acid on its latency-associated peptide, a methionine at position, a very specific position on the peptide that is redox sensitive. So the light-generated redox, irrespective of the wavelength, is capable of activating this growth factor. Now we know that TGF-beta is really important for wound healing, and the fact that you can activate it with multiple wavelengths of light is very attractive. But also the flip side, that the reason I think this paper is getting so much attention is that obviously we can activate one growth factor, but it's like the dominoes being toppled. So you topple the good domino and the right domino, and you can actually bring on a cascade of differences. So Victoria, why red light, and what are the other mechanisms?
Oh, first, we start to use red light because since we decided this research based on translational studies, it was the kind of light we use on those patients. So we decided to see how this wavelength would work on cells. And we know now in literature that red light, near infrared light, is very good for pain and also for wound repair. So this is why we decided using those parameters. And regarding mechanisms, we saw that the primary mechanisms increase in ATP, improve oxidinitric, and then we decided to see how those lights would work on secondary targets, which is growth factors. This is why we look for TGF-beta, VEGF, and PDGF, and metalloproteinases, and it was great, really great, the results.
So can you talk a little bit about the crosstalk between VEGF, PDGF, and TGF-beta, as well as the MMPs? What was happening with MMP 2 and 9? And how transient is it? How long does it take to recover from that? Obviously, if you have a hyperinflammatory phase, that's bad for wound healing. You get stalled in the inflammatory phase, but it seems it may be more of a transient kind of activation to kind of get things moving.
When we look for in vivo results, we saw that red light codon modulation MM2 and 9 that is in diabetic patients is decreased, and after we use photobiomodulation, we saw improvement of those metalloproteinases, which is good because we know how metalloproteinases can work in producing collagen and then improve wound healing. And then when we saw this on cells, in endothelial cells, we saw those metalloproteinases sometimes increase and sometimes downregulate, which is very interesting. And about this, Dr. Arany, I think he knows better because he's more experienced.
So that's exact. I'll pick up on that. So I think, Mitch, like you're pointing out, it's not going to always stay high, right? So even with TGF-beta, normally people think of TGF-beta and scarring, right? But many of the dermatologists and the plastic surgeons will tell you that laser revisions are awesome. I mean, you get very, very good results. And I get calls all the time saying, how can I be activating TGF-beta, right? If I'm activating TGF-beta, my scar should get worse. But it's the pulse of TGF-beta that is responsible for the remodeling. And I think as a part of the remodeling mechanism, the MMPs will change in concert, right? And they're not always going to stay up or down, and neither are the growth factors, but they come in pulses. And that's what, that is actually very helpful because it is letting us design a clinical treatment on when we want to pulse a particular factor. Because we know that the VEGF and the PDGF are usually a little more delayed than TGF-beta, at least in our cases, which starts the collagen production and the matrix reorganization. And then the endothelial cells have to migrate, proliferate, and then start organizing. So all of that clearly is a concerted action of multiple factors. It's not just one factor. But I think it's just going back to that domino analogy, we seem to be kickstarting that process. And this is very similar to what we do with chronic wounds anyways, right? If you think about what do we do with chronic wounds, we're just making it active. We are not debriding till we get an active bleeding margin. So the laser seems to be, the photobiomodulation seems to be doing this at the molecular level.
Can you talk a little bit about the HUVEC activation by photobiomodulation? It's really kind of interesting how, you know, you got more nodes, but it wasn't necessarily more tubules. It was a really interesting finding. I've done a lot of work on bioactive glass, and we see that it's so concentration dependent. And if too much of bioactive glass can actually stall endothelial cells completely. But if you get that right sweet spot, usually a lower concentration stimulates tube formation, and higher concentrations stimulate proliferation or cell migration. So please continue.
What you just said is the classical definition of photobiomodulation Arndt-Schulz curve, right? There is this term that we use where too little is ineffective, too much is antagonistic. But it's that sweet spot or the therapeutic window where you get. So you're using bioactive glass, we are using photons. But I think this is, a recurring theme in a lot of the biological responses. Too much of everything is not good, right? At some point, it starts becoming toxic. But how do we determine that seems to be, at least with the light treatment, with photobiomodulation, very uniquely placed. So one of the big emphasis of my lab right now is obviously the clinical dosimetry and the protocols, but based on the specific biological response that we are trying to evoke, right? So for example, and that's the reason that the endothelial cells were particularly attractive in diabetic wounds. In another project in the lab, we are looking at burn wounds, and the focus has shifted to macrophages. So we are trying to understand what is the right dose of light for macrophages. And when I say dose, it could be wavelength, it could be the intensity, it could be the duration, as well as repetitions. Macrophages come in between 2 and 5 days, and they're good guys in the beginning, but can get bad guys if they linger, right? So we are thinking of what is the right dose to traffic macrophages. And in this case, I'll defer to Victoria, but the nodes is unfortunately where we had to stop. We were actually very interested in going on and doing more studies, but she had to go back to Brazil.
I'm so used to looking at low mag at all these beautiful tubules forming in image J, and I'm like, oh, we're looking at nodes. It's pretty cool.
So Victoria, you could describe the matrigel system that you use. That was the beginning of your analysis, yeah.
Yeah, we use matrigel, and then we seed the cells on the top of this matrigel using light and the bottle of the plate. And then we could took pictures, real-time pictures, or sometimes we, as I remember, we'd cite some time points to take those pictures and see how those cells would growing, and we could see they spread on the plate. And I was curious too, because when we use the growth factors, we could see when we compare with and without growth factors, and it was really good when we use the correct growth factor and also with the correct wavelength.
So it could be when you think about this complex three-dimensional growth of these tubules. You get the solid cords, then they undergo luminization. And then if we had the cells, we would think of, smooth muscles coming in and lining those. So we know that PDGF has a latter role while VEGF is important in the initial role. But with the light, we seem to have kick-started the process. And as we saw with the different inhibitors, each one of them had a role, but they seem to be orchestrated. So it's not like you get, when you think about angiogenesis, you always think about non-productive or, malignant angiogenesis, which are not very productive. So it looks like when you do the PBM treatments, the control or the regulation is an inherent part of the endogenous response. It's unlike adding VEGF or PDGF in that site, because you would only drive one process, right? So that's what we think we are accomplishing with the light.
And I love that you thought about, looking at hypoglycemia and also had controls for concentration of solute, because I wouldn't have even thought of that, but it was a great idea to have those controls to make sure it's not just, just putting more molecules of something else in the liquid. So effectively, you gave the cells a candy bar of, what was it? What was the concentration? It's like 100 to 500. Was it millimolar or was that micromolar?
Millimolar.
Millimolar. Okay.
Yeah.
So one thing that I think, Victoria, I don't know if you remember, one of the very first experiments she was showing me, we were seeing that the cells looked perfectly similar, right? The control versus the hyperglycemic conditions. And as we were looking at the cells, we realized that despite the increased osmolality, they did not change structure. I expected them to become a little more bloated or shrunk in some way, but we were not seeing that.
Or something. Yeah.
Blebbing of some
That's
kind.
really good. Yeah.
So that's why we did those controls. Actually, Victoria very carefully looked at that data in terms of setting up the system.
And I love that you also controlled temperature. So normally when you're hitting with the laser, were you kind of cooling the cells down so when they'd heat up, they would stay at the same temperature?
You want to answer that?
This was very interesting because in the beginning of the experiments, it's okay, we find the correct concentration. So we saw that it was not dependent of osmolarity, but the real concentration was affecting cell viability. But for some reason, laser, it was not working. And then I came from Brazil, it's very hot here, so the weather is completely different. And then maybe Dr. Arany, this is not working. Do you think maybe this can be the room temperature? And then we had the insight to compare the heat and the cold and see how the cells would behave in different conditions. And what we saw that it was better for cells, and we control the temperature inside the plate and outside the plate. This is why I have to do many comparisons to explain people because and how this it was working.
I just wanted to add one more point to that. So people often ask us, like, is this like infrared sauna, right? Shine light and you feel nice and warm. And yeah, sauna is very nice and everyone feels, great after a session. But photobiomodulation is not thermal, right? So the maximum temperature, and we have done very careful studies, the maximum temperature we reach in a therapeutic PBM protocol is less than 45 degrees. So we are actually at the very edge of, what we would call hypothermia, but it's not, it has other non-visual phototransduction pathways. So it is not just heat. There is a temperature increase above physiological 37 degrees. So that is the range. And I think, I don't know, Victoria, if we mentioned this, but we have a patent around this. So we were able to file a patent around this, outlining that the range of temperature is actually, if people maintain that, they will see more consistent results.
So this was kind of a simple model system to start learning about things. What's next? We do a lot of kind of crosstalk studies between macrophages and fibroblasts and endothelial cells to understand oftentimes there's not just crosstalk, but also an additive effect of turning on macrophages to be from M1 to M2. That's very simplified, but the notion of if you have an angry macrophage next to an endothelial cell, it's not going to end well unless you get the macrophages to behave. Can you talk about what studies are next in the horizon?
So Victoria can talk about her clinical interests and her clinical studies. In my lab, we are actually pursuing some of what Mitch just pointed out, is the crosstalk between those cells, right? So fibroblasts, endothelial cells, macrophages are almost a synergistic kind of population that rely on each other for therapeutic benefit, right? Even the initial phases of fibroblast migration is co-migrating with endothelial cell. That's how you get those, granulation tissue that we love to talk about. So my lab is very interested. We actually have a review which is currently in second revision, where we talk about these microphysiological systems, right? So the big emphasis on three-dimensional organoid multi-lineage cultures is absolutely, I think, particularly for this treatment, because we have so many possible variables. We talked about color, we talked about power, we talked about repetitions. There are just so many possibilities that would be completely impractical to test in even animal studies, forget clinical studies. So I think developing these more sophisticated, cell culture lab models, I think is absolutely the way our field is evolving. And it includes exactly what you said, Mitch. We can even simulate, again, if I could keep Victoria forever, we had plans to do microfluidics and flow systems and, take it to the next level. We are seeing the formation of the vessel outline, but of course, are they functional? Do you actually get flow? Can they tolerate shear? So those were really, really good experiments that we would like to pursue. Victoria, you can tell us about your clinical studies interest.
Yeah. Then I came back to Brazil with those amazing results, and we saw that red light could improve pain and on the healing, but we saw in vivo results also in studying fibroblasts. And we saw that in diabetic people, those fibroblasts, what we did a biopsy and put this skin on a plate, and we evaluated the fibroblasts directly from diabetic patients. And when you compare with health people, when I mean health people without diabetes, and we saw like the way how fibroblasts work, it was different. So in photobiomodulation could improve this a lot. And after that, since we saw that what light can do, we decided to see and evaluate the pain profile of those patients, and we can see if we couldn't find a biomarker that can tell us what is going on with those patients, or if we could know if people with diabetes, how long they would develop wounds or not, what is the difference. This is what I'm looking now, see how the profile can change, compare people, and how lasers can improve those wounds and pain those patients.
Do you think red light could also prevent wounds from forming in the first place, prevent recurrence?
Prevent recurrence? We know that late have more results when we have a disease or wound or something. We also apply laser in healthy skin, and in my experience, I didn't saw difference. But when we're talking about pain, I think yes. When we talk about wounds, I don't know. Maybe Dr. Arany has a different point of view, but I think we can avoid or we can prevent pain in some cases if we use light, for sure.
So it'd probably be great for venous leg ulcers, right? To prevent pain. We see a lot of patients that are, elderly that have chronic pain with their VLUs, and because they're so frail, almost, compression doesn't really help them, and they really need something more than just compression. And pain is a big issue for these. Their quality of life is terrible.
Yeah.
So I think the strongest evidence, there are some well-done clinical reports, especially from Europe, on use of blue light and other light wavelengths for preventing wounds from occurring in the first place. I think the strongest evidence comes in supportive cancer care, where treating patients who are undergoing chemo or radiation with photobiomodulation before they get chemo or radiation has shown a reduced incidence of ulcers in the mouth and reduced pain. And even if it does occur, they have seen that the clinical grade is at least 1 or 2 points lower. So we believe that what is happening is we have heard this term preconditioning for muscle recovery and other forms of injury. With photobiomodulation, it seems to be, we have done some studies looking at integrated stress response in the endoplasmic reticulum and found that there is increased molecular resilience at the level of a cellular response. So if you try to hit the cell with radiation or chemo afterwards, you find that the normal cells actually are more resistant to damage. We have made those observations.
We're doing a lot of radiation studies now for some clients, and it'd be interesting to see if photobiomodulation would improve, patients, Mohs patients or patients that were exposed to radiation before and after, and looking at wound healing. Really exciting work. Are either of you going to innovations this week or down in the Keys?
We are not. I'm not. I don't know Victoria's.
You could come fishing with me if you wanted to go. Kyle's gone before. It's been really fun.
Yeah, I've heard of that meeting. Yeah.
I saw how cold it was in Buffalo after I watched the Bills game last night. Was it last night or the night before? It was.
Meeting has become a habit now, so yeah, the cold doesn't bother us anymore.
I love the lake effect snow and how beautiful it is when you're seeing people run around, fly around, play football. But it's fun. Thank you. Kyle, did you have any other questions, or do you want to wrap it up?
I'll throw in one more technical question, and then we can wrap it up. Because towards the end, we're talking more of the clinical applications, and as we talked about earlier, getting the right dosing is important. And with a wound, we've got a lot of changing scattering and absorption properties, and when I think about the photon transport, could you talk a little bit about some of the considerations when trying to dial in that dosing for a clinical application, where sure you want to deliver a specific amount to endothelial cells, but what are the keratinocytes, their melanocytes getting, and at what depth you think you're kind of hitting that right dose, and how do you deal with those challenges?
Yeah, so that's the whole, I just alluded to the term Einstein. It's basically a term that we borrowed from greenhouses, right? So if you go to any greenhouse anywhere in the world, the amount of radiant intensity from those lights to grow plants has been standardized. It's been optimized, right? So we are taking guidance from them, or rather inspiration from them, in terms of how much light is hitting the surface. Once the photon enters the tissue, the complexity of the interactions increases significantly. There are lots of nonlinear quantum effects, right? So there's this whole field of quantum biology that we are actually more and more getting integrated with because of the nonlinearity of the response. And also people who do radiation for tumor elimination, they do very, very careful estimation of their radiant intensity at the tumor site. So we've been inspired by both these fields. And to answer your question specifically, Kyle, because we are moving away from absorption, we are going to the absolute fundamentals thermodynamic transfer of energy. We have actually narrowed down on the wavelength necessary at your target site, right? So that is what we are paying more attention to. What happens in the transit zones remains to be fully examined carefully. But because it is so low amount of light and these are normal healthy cells, the responses are minimal, if any. It's only the ones which are actually diseased that actually benefit from the treatment. Interesting you said that, because the flip side of that is how, and we're doing this treatment for mucositis, right? So we are doing this in cancer patients. One of the key questions is, what if you have pre-transformed cells in that field, or have, even frank malignant cells in the field? Turns out that in those cases, the light energy is interpreted by the cells differently. Transformed cells use the energy very differently than normal cells. And there are some fascinating studies, both from the clinical literature, where they have not found increased incidences of recurrences or secondary tumors, showing us that the light is therapeutic and safe. but also in cell culture. Like we put a bunch of cancer cells in different conditions under different culture, simulations, and we can find that the malignant cells actually undergo excessive autophagy and apoptosis. And we have actually narrowed it down to why that happens, because these cells are very, very metabolically active and have very high levels of redox. So adding that extra energy seems to push them over the edge, right? Literally. And it causes actually the cells to eliminate themselves. So again, that has to be validated more carefully, but these are very, very intriguing in vitro observations.
I've one more commercial question. So if this is an energy-based device, right, then it's not chemical mode of action? Is it a device or is it a drug?
That's a great question. So as we are pursuing our patent, we keep getting asked, do you want to be a drug or do you want to be a device? And obviously the answer is a device. It turns out that the FDA actually, we had some informal conversations. So right now, although we are evoking a biochemical response, endogenous bio, especially TGF-beta, and we have looked at NF-kappa B signaling, and we've looked at ATF4 as a biomarker. So all of this we have done very, very carefully. The regulatory policy is they don't care about the evoke reaction. It is what are you putting inside the body and into the situation.
It's almost like a mechanical, energy-based mechanical stimulation, so you can be a 510K.
Right. Exactly that. So from the regulatory aspect, we are still a device. But then again, there are some efforts at, combining the light with other, topicals and other agents. So that's when you become a combination. But we do not get classified as a drug for the good or the bad, because, again, there are two sides to that coin. But and unfortunately, I think that's what's held the field back, because this was very recent. So 2023, the FDA recognized photobiomodulation as a separate kind of light treatment. This was very, very recent. So I think that has actually given a lot of recognition and credibility, if you will. We didn't even have a term, right, to call this treatment. Everybody called it low-level light treatment, infrared light therapy, red light therapy. So I think all of this is going in the right direction in terms of a medical device standard for a credible, mechanistically rationalized treatment.
I would one more question. I'm sorry. The many people have used light to also reduce bacterial biofilms or prevent bacteria from growing. Does this red light, is that sufficient enough to stop bacteria from dividing, or is it bacteriostatic, or is it bactericidal, or not?
Victoria, you want to take that, or should I?
Oh, for this kind of wounds, for example, when you have bacteria, you used to use PDT, photodynamic therapy. So there is a combination of light with what is the name, Dr. Arany? It's a
photosensitizer, a chromophore.
Chromophore. So in this case, photomodulation works very well. But we call this PDT because you use the photosensitizer.
So when you're using the killing action of light, either by itself or with a photosensitizer, it is the photodynamic action. So that is discrete from photobiomodulation. Photobiomodulation should be non-destructive, non-thermal. That's how we are trying to divide. Because PDT, as you know, Mitch, is a up-and-coming technology. It's been around for a while, but I think it's getting a lot of attention because of antimicrobial resistant bugs, staph and MRSA and all these other VREs and stuff. So I think people are realizing that killing with light is also possible. And we're not talking surgical ablation. We are talking about targeted redox generation. I teach a lot of undergrad classes, and I talk about it as dentists love hydrogen peroxide, right? So we use hydrogen peroxide for all kinds of things. So it's light-generated peroxide, right? You're actually creating ROS very locally. And that's a great way of eliminating bacteria, fungus. We have all these nasty fungal infections now in dentistry. It's turning out to be extremely effective inside the root canal, in the furcation areas. Very difficult to mechanically reach these areas. PDT is turning out to be a real game changer, but it can be further supplemented with photobiomodulation. So that's how we think about it. It's a synergistic field.
Really cool. Anyway, thank you both for a wonderful fireside chat. Kyle, thank you again for being on. and look forward to seeing you at WHS SAWC in the spring. And congratulations on your wonderful work, and look forward to following you in your next papers coming up. Take care, guys. Thank you, Kyle.
Yeah,
Thank
thank
you.
you for having
Bye-bye.
us. Bye, Kyle.
Cheers.
Bye, Mitch.
Bye.
Bye.